And thank you for spending some time today with Dr. Casey Rondello, our university epidemiologist, just cutting through the noise and understanding Omicron. This is Casey Rondello's second forum this year on the coronavirus, and our health and wellness team has had several other open discussions in regard to the pandemic, steps taken, and vaccines. I'm glad to see so many people on the call today. I see students, faculty, staff, trustees, alumni, and even parents on the call, so that's really great. I want to also thank everybody that's on this call as far as getting through the semester safely. I'm pleased to report that we did really good up until 2 weeks ago. Our average positivity rate on campus was just 0.1%, which really shows our dedication and commitment to safety, how we took vaccinations quite seriously, and the other mitigation steps that we put in place to be able to get through the semester. Unfortunately, the past 2 weeks, we have all seen an uptick in positivity cases, but yet our positivity rate just went from 0.1 to 0.6, which is still extremely low, especially compared to some other colleges and universities that we've all read or seen in the papers that coming back from the Thanksgiving break, there was some upticks as it relates to COVID positivity cases. That being said, we're here to hear Dr. Casey Rondello. So have your lunch, sit back, relax, and I'm going to turn it over to Dr. Rondello. Casey?
Thanks, Gene. One of the first questions I inevitably get asked lately is most important thing, how do you pronounce this variant? And you said Omicron, and I say Omicron, and I thought a couple of days ago I better find out. I'm not a Greek scholar, but let me figure this out just so that I don't do all these interviews and forums and meetings and be mispronouncing it. Turns out both are accurate, so I'm happy to say that we are both okay. Omicron or Omicron, and we'll be talking, the bulk of our conversation today will be about understanding the new variant. But before the presentation begins, I do want to, since I have the audience, make a few comments about Adelphi's overall mitigation strategy in light of what you mentioned, the recent acceleration of case transmission that we've seen throughout the country, particularly in the New York, New Jersey region, driven in part by the Omicron variant, which, as you know, is the primary topic of today's discussion. Adelphi's Health and Wellness Division, which is informed by our surveillance team, which consists of epidemiologists, clinicians, and administrators, monitors national, state, regional, and our own campus COVID metrics on a daily and, depending on what's going on, sometimes hourly basis. And based on several data points, like overall number of active cases at any given time, or the current positivity rate, we have an alert system that prompts possible changes to our protocols, such as a move to distance learning, if we reach certain trigger thresholds. Fortunately, thus far, we have only reached that point where we would consider making a change once in the entire COVID experience at Adelphi, and we took corrective actions, which very quickly brought us back down to below the alert threshold. Having this alert system in place is one of the reasons why Adelphi's infection rate has consistently remained below that of our surrounding community and many other institutions of higher education. As of right now, we continue to be below the levels that would necessitate the surveillance team to consider a shift in our mitigation strategy, but things are changing very quickly, and we have our eye on that ball, and so we remain at the edge of our seats, ready to take those steps if and when the situation warrants. I'll also say, as a reminder, that whenever a case occurs in a member of the Adelphi community, a thorough contact tracing protocol is initiated, which we do in collaboration with the Nassau County Department of Health. That's done for a couple reasons. It's done in part to alert individuals, any individuals who might have been exposed, to take appropriate steps. But it's also a tool for the epidemiologists to track and try to understand how the virus is spreading on our campus, to see if cases are related to one another in any way. And I'm glad to say that to date, almost all of the cases at Adelphi that have occurred amongst students and employees have been isolated and unrelated. And there have been a very limited number of exceptions, but by and large, the cases that occur on campus are not a part of any cluster from the same classroom or the same dormitory or the same, academic department or the same student organization. And that's critical information for those of us on the health and wellness team as we piece together how best to protect members of the Adelphi community. And our strategy, as you know from the beginning, in approaching the pandemic, literally from day one, has been to rely on layered protections, as no single prevention tool, whether it be vaccination or testing or any tool, is singularly infallible. And so that layered approach, that careful contact tracing, coupled with our surveillance testing, which is ongoing among high-risk populations, our testing requirement before large events, our stringent, conservative, frankly, quarantine protocol that goes well beyond what is required of the state and the county. Really all the precautionary measures that we take, from indoor mask usage to room capacity limits, they have served us extremely well. And while we thought that would be the case in theory, we now have a year and a half of experience and track record that validates our strategy, and that track record bears it out. So anyway, I know that everyone's got attention turned to Omicron, and that's what I want to transition to. But I thought, while I had the ear of a number of people, that I make a few comments about what our thinking is as we enter sort of this new chapter of the COVID experience. So I'm gonna switch over to some PowerPoint slides to guide me through this presentation. And the first couple slides that we go through are going to be somewhat familiar to you, not in the data because the data is new, but in the way that they're presented. And I'm going to go over them pretty quickly because they're not the primary focus of today's discussion. I want to bring them up, however, to give you a snapshot view of where the country, the state, and the county are at in terms of our epidemic curve. And I've talked about epidemic curves quite a bit, and you've seen quite a few from me. So I want to just talk you through where we're at as a launching point before we get into the conversation about variants in general and about Omicron in particular. All right, so someone just give me a heads up and let me know that you can see my PowerPoint slide.
You're all good, Casey.
Great. Okay, thanks. I'll start off by saying to everyone, happy anniversary. Tuesday marked the anniversary, the 1-year anniversary of the first COVID vaccination in the United States. By any measure, a medical triumph that ranks among the greatest, certainly of my lifetime and very much of this last century. Anniversaries provide us with an opportunity to take a step back and to reflect on the past. And so the timing of today's talk is particularly fortuitous because it gives us the opportunity to look back on the last year and a half, consider how far we've come, and think about how we can best use that experience to inform what we do moving forward for the remainder of the COVID experience. So here's some summary data. And again, I'm going to go over these first few slides very quickly. Just a few things to point out: that we are in a period of great growth in terms of both cases and deaths nationally and regionally here in New York. As you'll see graphically in a moment, we're very much at a point of something new happening with COVID. And for those that were at my previous chat, I showed you some models of how COVID could play out. And there was a lot to look forward to in those models, but I was careful to say there are basically two caveats that make all of this modeling essentially defunct. One is if there's a change, one presumption is that the vaccine is approved, for younger folks, and that there's significant uptake in that cohort. But the second, which is a big one, as I said, we cannot have a highly communicable, transmissible variant like Delta emerge, because that would throw all of this modeling off. And lo and behold, here we find ourselves with a very different clinical forecast for the coming weeks and months. Here's the epidemic curve for the US on top and New York on the bottom. Again, note the ways in which they're similar and the ways in which they're different. Particularly look at what's going on here. This demonstrates in a very clear graphic way that we are entering a new phase of the pandemic. This next slide takes this bottom curve and puts it on top. I can only fit two on the slide, but we're going to take this New York graph, put it on top, and I'll put Nassau County on the bottom. And here you can see this is the New York, this is the Nassau County. For the most part, very reflective of one another, but this is really the point you need to be paying attention to. This is a near vertical line. There's no scenario in which this goes down from this point immediately, right? There's really only one trajectory that the slope of this curve is going to go in the immediate future, and we all know where that's headed. Here's a shorter timeline snapshot of Nassau County over the course of the last several months rather than the whole COVID experience. And you can see that, things were looking substantially improved as we entered the respite period, basically, of the fall, before we began to see an acceleration of cases that began really in earnest with the Thanksgiving holidays and has continued unabated, and will continue to do so for the foreseeable future. I want to show you a heat map. I like the way, I try to present the same data in different ways because I know that its presentation speaks to different people in different ways. And so depending on how you best absorb the data, I want to present it in a couple different ways. This is the same information that was presented on the epidemic curve, but in a different form. It's a calendar heat map. And you can see this is for Nassau County. What's a little different about this is at cases per capita. So it takes into account the population density of our county. The darker the colors here, the greater number of cases per capita. And you can see the periods during which we were most severely impacted in Nassau County by COVID. This anecdotally makes lots of sense to you if you think about what happened in Nassau during wave 1, which was right here. And then wave 2 was pretty negligible. It was wave 2 for the US, but for our area, given that we were hit so hard in wave 1, really didn't have much of an impact. But then wave 3, which was the holidays of 2020, really was, you see, obviously the darkest color. And that was, the most substantial part of the pandemic in terms of new cases, hospitalizations, and deaths in Nassau County. And I'm sorry to say that as you look at the most recent days here, we are very quickly ramping up to the level when we were at our peak. So that's all I really want to talk about in terms of the epidemic curve and in terms of prognosticating where we're going in the next few weeks. I really want to spend the bulk of the time today talking about Omicron, variants in general, and Omicron, because I know it's gotten a great deal of attention in the lay press, some of which, frankly, is very deserved, and some of which, may be premature, depending on what you're listening to. But in order to sort of, to Jean's point, turn down the noise a bit, I want to let you know what my impressions are as of this moment of the COVID variant known as Omicron. One point that I'll make before I even jump into it, excuse me, this is a very new and evolving situation. That's a good thing and a bad thing. It's a good thing in that it demonstrates that we are at sort of the bleeding edge of what's known about this particular variant. it's good that we're having these conversations now and not months from now. On the other hand, the bad part is that we have to acknowledge that there is still a great deal unknown, and even the things that are known, some are in conflict with one another. And so trying to parse out what's the reality, and this is what I recommend others do, generally apply the legal principle of preponderance of evidence. I go to all of my, most trusted sources, and, I believe what the preponderance of evidence dictates. In other words, what is more likely than not. And so when I get into the conversation about Omicron in specific, I'll do my best to let you know what is believed by most. You need to bear in mind that this is very early on, and there are dissenting voices out there, which may or may not be wrong. But as of today, the 17th of December, this is what is believed by most experts that I know and trust, and also believed by me. So before we talk about Omicron in specific, I want to spend a little bit of time and talk about variants. I was having a conversation with Gene, a couple of days ago, and he said, well, will there be another variant? And the answer to that is, chances are very high, yes. So while I do want to talk about Omicron, I do want to kick things off by discussing variants in general. Here you see a graphic representation of just how the variants have occurred since the wild strain, which is over here, has evolved with time. You see the Delta strain and all of the substrains in this, I guess, greenish teal color. And you see the Omicron strain, which, like I said, is very new on scene. I'm going to show you just how new in a few minutes, but that's represented here in the red color. But here you can see the branching of basically the genetic tree from the wild strain or the base strain to the varying variants, both in terms of number, which is on the left, and in terms of where they appear on the globe, which is on the right. Now, a couple things to say to start off here. Number one, remember that variants are completely expected. We know that this is going to happen. We know that variants are predominantly going to emerge in those regions of the world with low vaccine coverage. We'll talk about Omicron in a moment, and it was really South Africa that fired the first flare and said, this is a problem. South Africa is a country with a vaccine coverage of, depending on the estimate, anywhere from 25 to 30%, less than half of what we have here in the United States. That's consistent with where we think that these variants are going to emerge from. Remember that most, there are hundreds and hundreds of thousands of variants, and that most variants will have no impact on transmissibility, on severity, and in fact, some variants will have lessen those characteristics, be less communicable or less virulent, right? But we're really only concerned of these thousands of variants with those that are going to have an implication for clinical practice. And that means, as you'll see in a minute, that they're going to impact our vaccines, or they're going to impact our testing, or they're going to result in more severe disease, or they're going to spread more readily than either the base strain or the other variants that have emerged thus far. The best way to control variants and to limit the number of new variants is very simple. It's not rocket science. It's to decrease the number of cases, right? Every time a case goes from one person to another, it provides a window of opportunity for a variant to emerge. And so the way you get variants down is you get case transmissions down. And the way you do that is by getting overall case volume down. So the history of variants in the United States has occurred in waves, okay? Earlier versions of coronavirus, such as including the base strain, that's here in the lightest gray. And if you remember, the first real variant that probably showed up on your radar was the Alpha variant, or what we called then the UK variant or the British variant, right? That was before the WHO adopted the Greek letter nomenclature that we now use for the most concerning problematic variants. But you can see that pretty quickly Alpha dominated and became the predominant cases. Very quickly after that, you see, while there was a little bit of activity with iota, gamma, mu, and beta, that it did not take long before the Delta variant, which was initially identified in India, the Indian variant, became the predominant one in the United States. And it's important for me to tell you that it remains the case today. So I'm going to show you what the variant portions are in the US and in our region in a moment. But it's important to acknowledge that as much attention as Omicron is getting, and as fast as Omicron is spreading, that Delta remains, at this moment, the greatest threat in the United States, and remains, proportionally, substantially, the highest number of cases identified are of the Delta variant. Now, not all variants are equally problematic, and not all variants are of equal concern to clinicians and epidemiologists. The CDC has a mechanism for classifying basically how concerning a variant is, how bad a variant is. And it takes variants and it dumps them into one of 4 buckets. These are important to know because it allows you to assess how big of a deal is this? How much should I be worried about this? You can tell by the variant classifications, and there are 4, okay? They are variants being monitored, or VBMs, variants of interest, VOIs, variants of concern, VOC, and variants of high consequence, or VOHCs, okay? A few notes before we get into what these 4 categories mean. Number 1, each category includes those of the earlier classes. So in other words, the characteristics of a VOC include the characteristics of a VOI and the characteristics of a VBM, in addition to its own characteristics as a variant of concern. So as you move down the list, you continue to keep those characteristics of the earlier classifications. Number 2, once a variant lands in one of these buckets, it may or may not stay there. The variant's status may escalate or de-escalate depending on the real world situation, right? Based on emerging scientific evidence of whether it, in some way, and sometimes it de-escalates. Threats like Alpha, for instance, were variants of concern, and as you can see, are far less proportionally in the COVID that we see today, and so they move down the scale. On the other hand, you have variants that come on scene and we don't think they're going to be a problem, and as time goes on, we see they account for a greater proportion of illness, or we learn more that they cause more severe illness or something, and then that moves up, it escalates up the variant classifications. And finally, bear in mind that the US classification may be different from that of the WHO, in part because the impact of variants varies depending on the location. So what's most problematic here in the United States may or may not be most problematic when you're looking at the globe altogether. So let's go through these 4 and just explain what they are very quickly, a little Cliff's Notes version, just to give you an idea of the stratification of variants. First off, VBMs, variants being monitored. All variants circulating in the United States start off as VBMs. Basically, there's not really much that's noteworthy about a VBM other than we've identified it and it has the potential to cause harm. It's circulating at low levels, but we are surveilling for it and we know it's out there. But at this time, if it's a VBM, it is a variant that does not pose a significant and imminent threat to the public health and community health of the United States, and therefore it stays as a VBM. All right, so what's a VOI? A variant of interest is a variant that, as a consequence of its biology, is potentially a threat. So in other words, it has genetic characteristics that trouble us. Its genetics, its genetic markers, we believe may, and you see all the mays in red here, may result in changes to receptor binding or how readily it can attach to cells. The genetics dictate that it may reduce our antibodies' ability to neutralize the virus. It may reduce the efficacy of our treatments like monoclonal antibodies and so on. But the key thing here to remember is that none of these things have come to fruition yet. It's all may, it's all possible, it's all theoretical based on the biology, and therefore it's classified as a variant of interest. A variant of concern is when we have a variant of interest and now we have evidence that it's doing what we feared it would do. It is one or more of these things. It is more readily transmissible. It is causing more severe disease. In other words, more people on ventilators, more people in ICUs, more people in hospitals, and so on. It may have a greater impact on neutralizing the effect of antibodies. It may result in reduced effectiveness of our vaccines. It may have the ability to evade our diagnostic tests so that it has evolved in such a way that it's harder for us to pick up on testing. That's what makes for a variant of concern. And this is what Omicron and Delta are right now. And then finally, it's important to know that this is a 4-step scale, and we're only talking 3 steps so far, which, brace yourselves, because there is a 4th step, and those are variants of high consequence. To date, we have had no COVID variants of high consequence. That's a very good thing. If we have a variant of high consequence, the implication is that this variant has evolved to such an extent that our prevention and MCM, medical countermeasures, MCMs, have substantially been impacted such that the primary tools that we use to combat the pandemic are no longer valid, or primarily no longer valid. That means, that it would, if we ever get to the point where we have a variant of high consequence, that would require a rethinking of our national strategy to contain the pandemic, and it would necessitate, new treatments, new vaccines, and so on. Like I said, I'm happy to say that we have not had any variants of high consequence, and hopefully it'll stay that way. So here's a summary of some of the variants and where they fall in those buckets. Variants of concern. This is according to the New York Times. If you look at the CDC data, this is an example of where it's a little different. CDC really only considers VOCs to be Omicron and Delta at this point. But variants of concern and variants of interest, along with some of the mutations, and we'll talk about these mutations in a minute when we get to Omicron. The national proportion of variants is different than the proportion of variants that we see in our region. The way that the CDC cuts up the country and looks at the different regions of the United States is using FEMA regions. And our FEMA region is New York, New Jersey, Puerto Rico, and Guam. It's just the way that FEMA cuts up the country. The data I'm about to show you is not for the United States, but it's more specific to our FEMA region. This data is collected once a week. And what you're about to see is the data that ended the week of December 11. That means this data will be updated tomorrow, the week of the 18th, and I suspect it will be substantially different. Here you can see that for a long time now, and this is week by week, the predominant strain by far in our region has been Delta. But all of a sudden, Omicron has come on scene. That's in the purple. Right now, Omicron accounts for over 13% of cases in our region. That is the national leader. In much of the country, Omicron accounts for about 3% of cases of COVID. Much like at the very beginning of the pandemic, New York is the tip of the spear, and we are experiencing first what the rest of the country will be experiencing in the weeks and months to come. Okay, like I said, this is data that ended on the 11th. I assure you that it will be a substantially higher proportion by the time the next week's data is released. That's the data week ending on December 18. This is happening very, very quickly, and the situation is unfolding, faster than any thing that's happened in the whole experience of COVID. In fact, Omicron is doing in weeks what Delta took months to do, and Delta, did in weeks what it took the base strain months to do. So we're talking about an extremely accelerated timeline. Let me show you just how fast this has all happened. The new variant, which back then we didn't know what it was even called, we didn't have a name for it, was first detected in Botswana about a month ago on November 11th. That same variant was detected in South Africa 3 days later. Now, give credit where credit's due. It was South African scientists' decision to raise a red flag very, very quickly, okay, that led to our understanding Omicron and being on the alert for Omicron globally in a way that we have not been able to do for other variants. Now, like I said, that's good news and bad news, right? The good news is that by sharing their data so quickly, and this is in contrast to the Alpha strain and the Delta strain as examples, by South African scientists not only saying, we're detecting something awry, but they shared the genetic code of what would soon become Omicron with scientists around the world. That allowed researchers, for instance, in Sweden to say, we're going to look for this specific genetic code, and lo and behold, boom, we find it. That allowed them to identify the variant in their country, far faster than they would have otherwise been able to do. And so there's still a lot to be learned because this is happening very, very quickly. But to their credit, South Africa brought in, global partnership at a very early stage in this, rather than sort of bide their time. And that has allowed us to be extremely proactive with Omicron in a way that we have not been able to do with other variants. South Africa reported to the World Health Organization the variant known as B11529, which is the same thing as Omicron. It did not take long, only 2 days, for the World Health Organization to acknowledge this is a problem. So we are going to classify it as a variant of concern, and we're going to give it the Greek name Omicron. It took only 4 days after then before the CDC said, you know what, we agree. Omicron is a VOC for the United States as well. The next day, the first case of Omicron is detected in the US, I should say New York. December 3rd, first cases in New York and New Jersey. And then, and this is how you can see how quickly it escalated. December 4, Omicron accounts for about 0.5% of cases in the US. And on December 11, okay, a week later, Omicron accounts for about 3% of cases in the US. And as I showed you earlier, for us here in New York, that's actually 13%. This is where Omicron is globally right now, as of yesterday. Actually, I didn't check this morning, but as of yesterday, the US, as a consequence of Omicron emerging in South Africa, has implemented travel restrictions for 8 countries in Southern Africa. Some countries like Israel, Japan, and Morocco have ceased all international travel from any nation at this point. This is where Omicron is in our country. Again, this is data as of yesterday. It probably has gone up since then. So the last piece of what I want to share with you is about Omicron, what is known and what is suspected. Again, this is all based on the preponderance of evidence. So Omicron has a massive number of mutations, more than 50 mutations that have not been seen in this combination before. Of those, 30 of these mutations occur in the spike protein, which, if you'll recall, is essential for the binding of the virus to human cells. Okay, several of the mutations that we see in Omicron, and you see the 3 of them listed there, are mutations that we already know make variants more infectious. So our experience with other variants has been that if you have these mutations, you become more infectious. Both scientifically, genetically, and now in our own anecdotal experience, we can say with confidence that the Omicron variant is highly transmissible. In fact, even more transmissible than Delta. and far, far more transmissible and communicable than the wild strain. As a consequence, it is very likely to supplant Delta as the dominant strain in the United States very soon, okay? We also know that Omicron is likely to cause no more severe disease than the base strain or the other variants like Delta. In fact, there's some limited evidence from researchers in South Africa that have shown that individuals infected with Omicron have about a 30% chance, 29% chance, lower chance of being hospitalized than those who are infected, that were infected with the wild strain at the beginning of the pandemic. That seems to indicate a less severe clinical presentation. So kind of a good news, bad news thing. What does this mean? This means that our concern is not so much about this causing more severe disease. The greater concern, and this has enormous implications for healthcare systems, is just the volume of patients this is going to create. So not more severe illness, but more sick people. Just a massive, in one research, in Osterholm's words this morning, tidal wave of sick individuals, which may very well inundate healthcare systems, particularly in regions of the country where vaccine coverage is especially low. Okay. We also know that the Omicron strain is more resistant than the base strain to neutralization by antibodies that have been conferred either by vaccination or prior infection. The implication there is that vaccines are less effective in preventing Omicron-derived illness than the other strains of the virus. Now, how much less is a matter of great interest right now and a matter of considerable debate. I've been in meetings for the last 7 days, hours upon hours upon hours, with researchers debating that single question. There are lots of numbers that have been thrown about. I'll tell you that a key component to all of that analysis, and now we're going to get to that on the next slide, is that the vaccines, while less effective, will be substantial enough efficacy in order to combat this at this time. We'll talk about that in a minute. Okay, there's a limited amount of evidence to demonstrate. UK study demonstrated that perhaps, this is a big question mark, higher rate of reinfections with Omicron. So let's talk about the vaccines and the Omicron variant. This is the big takeaway. Current vaccines will protect against the most severe disease, hospitalization, and death. So while the vaccines are less effective in preventing illness from COVID overall, they continue to be dramatically more effective in preventing basically the most serious disease is going to end you up in the hospital or on a ventilator or in an ICU. Researcher at La Jolla said, for the general public, the good news is boosters are going to work, full stop. And that's an important point. So there's a massive difference that we've already detected in resistance to Omicron, whether or not you have been boosted. In fact, the efficacy of the vaccine in preliminary data seems to double from what you get from the completion of the 2-shot regimen to being boosted. So what does that mean? That means the boosters were always going to be important, but it means that in order to maximize your protection, more important than ever is that you get your booster on board as quickly as possible. And that's because, especially as it relates to the Omicron variant, you are going to substantially improve your immunological protection once you are boosted. In fact, estimates are it will double from what it would be if it was simply, the completion of the 2-shot regimen. Now, there's some conversation about whether or not an Omicron-specific booster or Omicron-specific vaccine is going to be necessary. And at this time, it looks like it will not. It looks like individuals who are boosted will have sufficient protection both individually And as communities become covered with boosters, collectively, that will be sufficient to prevent the spread of Omicron in populations, community health-wise. However, like I said, this is a very new situation. And so research has already begun on a revised shot of the vaccine for Omicron. Should that be necessary, it would begin to be ready as early as March. But that is not something that is, beyond discussion phases. That's not something that's been planned, that's being planned for, because it's at this point seemingly unnecessary. You'll know that boosters are not yet recommended for minors, and that continues to be the case. Too little data to determine whether or not boosters will be necessary. What do we do about vaccines in the future? There's basically two strategies. And just to quickly bring this up, one strategy is that we continue to chase variants and potentially create variant-specific vaccines to address them, very much like we do with influenza. Annual shots that are carefully crafted to contain the variants that are most troublesome, most problematic. A second approach, which is more complicated but would be more comprehensive, would be the development of a pan-coronavirus vaccine. One of the meetings I've been in was in researchers who are working on this. There are several efforts, some military, some civilian, to develop a pan-coronavirus vaccine. And should it be ultimately viable, this vaccine would cover not just COVID-19 and all of its variants. It would cover all coronavirus-derived disease. That includes SARS, and it even includes some of the viruses that cause the common cold, believe it or not. Common cold is actually caused by a myriad of different possible viruses. 4 of those viruses happen to be coronaviruses, and you'd be covered for those 4 coronaviruses should you get this vaccine. This vaccine, the pan-coronavirus vaccine, will enter into clinical trial testing in about a year. And so this is a sort of a long-term plan, but ultimately developing a pan-coronavirus, much like, by the way, developing a pan-influenza virus, which is another effort that's underway, really is the long-term solution to all of this. But that's not going to happen. Shots aren't going into arms until well after a year from now. Finally, I want to end on some practical advice for the holidays. I know that we're all sort of entering into the holiday period where we're considering gatherings with family, with friends, and so on. And so I thought it'd be prudent to throw up a slide and offer you my practical advice. We know that the risks of someone vaccinated versus someone unvaccinated are so substantially different that I'll tell you, I would not feel comfortable, and this is based on many years of education and a long career as a disaster epidemiologist. I would not feel comfortable at this time with what's going on with Omicron being in a setting with unvaccinated individuals. Unvaccinated individuals, both nationally and globally, are the reason that Omicron exists. It's the reason that variants emerge, and unvaccinated individuals pose the greatest risk, not just to themselves and not just to others, but to the continuation of the pandemic. Back in the words of the commissioner of New York City, who was in a meeting I was in earlier this week, vaccines remain the best public health measure to protect people from COVID-19, to slow transmission, and reduce the likelihood of new variants emerging. That is undebatable science. And so that's a personal choice that folks made as to who they're going to be, in these various, holiday settings with. That's sort of where I draw the line for me. As I mentioned for reasons earlier, boosters are more critical than ever before. Remember, masks continue to offer protection against all variants, including Omicron, and that's why universal mask usage in indoor public settings is becoming the norm once again as we enter this new phase of the pandemic. It's also the reason why Adelphi has continued to implement a mask mandate regardless of vaccine status. I know it's hard for us in the colder climates, but remember, outdoor spaces are far safer. And when you can't be in an outdoor space, consider in somehow augmenting ventilation, perhaps with fans or through open windows when possible. And finally, this is an important piece that we didn't have last year. We actually didn't even have even a few months ago. Home testing provides an important tool that we now have. I remember talking about testing in meetings, a year and a half ago, saying at some point we're going to have home tests, and you're going to be able to test in your home in a matter of minutes whether or not you or others likely have COVID. And while these tests are not infallible, they are extraordinarily accurate, especially when conducted in the way in which they're intended by following the instructions. Well, we're getting there, and home testing is here. It's getting cheaper and more available every day. Right over there, I have a case of them, right? You can get a box of 2 tests, the Binax Now tests, for $14 now, and the price continues to drop. When you give these tests, obviously it's essential. That is an essential piece of this. For gatherings with my family, we're testing, 24 hours in advance. Know that the accuracy rates of these tests are on par with the rapid tests that you'll get at, CVS or anywhere else. The chemistry of the test kit is the same. Really, you just have to do it in the way in which it's indicated on the box. And this is, I probably should have put this in red. This is important. The FDA has tested not just the tests that are used in laboratories, but tested the tests that are available to home, for home use. And most have successfully detected the Omicron variant. This slide demonstrates 6 of the tests that the FDA has validated as being able to detect the Omicron variant. These are the most common tests that are available over the counter, by the way. The tests that did not pass muster, and you can find them, on the FDA website, they are less readily available. So really, the tests that are most out there are the ones that are inexpensive, generally speaking, easy to use, and valid for detecting if Omicron is what's causing the COVID. My last slide, I'd like to offer some final thoughts. Variants are going to be a part of our life forever. That part of this is unavoidable. What is not unavoidable is the number of variants that emerge. That is wholly within our control. I started this conversation by noting Tuesday was an anniversary. Anniversaries provide an opportunity to think back. And I've spent some time thinking about all that's happened since the first shots of COVID went into arms. And in fact, even before I had heard there was a new coronavirus in China, long before it had a name, no one could have anticipated how the pandemic would play out. Even we disaster epidemiologists who've spent our entire careers preparing for this eventuality could not have predicted the twists and the turns that COVID-19 has taken. But what I found is that more than the knowledge, more than the forecasting, more than the medicines or the masks or the vaccines, the most critical tool that we have had the entire pandemic has been our resiliency. It's been our adaptability. It's been our ability to flex, to emergency remote learning, to mask requirements, to distancing protocols, to all the evolving risks and threats. We figured it out, we adapted, and we overcame. And so more than any drug or any mask or any single protocol, our biggest asset has always been our resiliency. And so I'll tell you on a personal note, as I wade through what can be very troubling data, and I sit in meeting after meeting with worrisome forecasts and trends, I personally am comforted in the knowledge that we'll be okay in the final chapters of COVID because we figured out how to navigate through the first ones. I hope you are similarly comforted by the history of how we've gotten to this point and know that those same strategies and that same resiliency is going to carry us through. With that, I wish you a warm and wonderful holiday season, hopefully spent with those that you love most. And I'm sure I'll be back, and I'll see you again next year. Gene, back to you.
Sure. Dr. Rondello, we can't, as a community, thank you enough for your leadership, your expertise over the past 2 years. Your knowledge has helped us steer a strategy that definitely has helped Adelphi University safe, our infection rate low, and we can hope to continue that same momentum. I'd like to remind everyone, as always, if there are any questions, please do not ever hesitate to email healthandwellness@adelphi.edu. That's health and wellness at adelphi.edu. I echo what Casey said. Everyone have a safe, enjoyable, relaxing holidays. But please, let's remember what Casey left us with as far as those strong mitigation steps of what we need to do to have a safe, enjoyable holiday. See you next year, everyone. Bye-bye.